Okay, so now we're going to talk about examination of the patient. So you've taken your history, now you want to examine them. I hope you've had a look at the video. I think it was very useful, slightly funny, but very useful, and it shows the extent to which you may have to examine the patient. So just a few notes on that. It's always useful to get permission from the patient, as with any examination, get that verbal consent at least, so that you and the patient are clear on the expectation of an examination, especially with dermatology, when you may need to examine several areas of the body and maybe even need to do intimate examinations. And always offer the patient, if they want a chaperone. In my practice, I always offer the patient a chaperone, especially if they're a female patient or of the opposite sex, and then that can obviously be documented. Unfortunately, in this day and age, with increasing medico-legal issues for doctors and other medical professionals, it's always worth clarifying whether or not a chaperone is required, and then you can always document that in the notes. Lighting is incredibly important. I carry around my dermatoscope all the time, and I can't do my skin examinations without a decent light. You can also get minor surgery lamps if you're lucky enough to have one in your room. I've got a well-challenged minor surgery one, which is really useful, and I'll put a link for it in the notes. It also just makes a big difference when you're examining, and lets you differentiate between different skin diagnoses. So perspective, always take a step back first. The patient wants to show you their rash, but don't rush in. Take a step back. With your normal examination, you do your inspection first from the end of the bed. I suggest you do that with skin as well. It gives you an idea if there's a rash and an eruption. You can see the symmetry of it, asymmetry, and the distribution. And also with skin lesions, you can see if people are photo damaged or if they've got a variety of those similar lesions, because that'll make you less worried as well. And then you can zoom in to examine your patients in a bit more detail. Always palpate and feel and stretch the skin as and when required, and we'll just come on to that in a bit. And like I said, examine the whole patient. So ideally, with even dermatology patients, you want to try and examine the whole patient, look for rashes and eruptions, because they can be in certain areas where the patient doesn't quite see them or can feel them. Same goes for skin lesions. So for example, I remember being asked to see a patient. I popped in to see a colleague's patient, and they had a little lesion, a seborrheic wart on their chest. I noticed he had some photo damage, so I just asked to quickly see his back, and we picked up 4 BCCs on his back, which he'd never seen, and they'd obviously not bothered him either. So it's useful to dig around. And also have a wide-angle lens approach to your examination. Don't just examine the skin. It's also important to look at the patient's hair, scalp, looking at their nails, and the mucosal surfaces as well. So inside the mouth as well gives you some clues. So for example, there's a condition called lichen planus, where you can see Wickham striae in the mouth. Psoriasis has lots of nail manifestations and also affects the scalp, so it's always useful to examine. And again, with your skills of pattern recognition over time, you will pick up these clues, and it just makes your diagnosis easier over time. So the 2 tools I use commonly, the Woods lamp, not so commonly, but this gives off a UV light and can pick up fungal infections and another bacterial infection called erythrasma, which is caused by Corynebacterium. Really useful. You can pick them up fairly cheaply. There's the official Woods lamps, but I actually got one from Amazon. I call it a piss torch because it detects cats and dogs' urine with UV light, but it gives off a nice concentrated light. Again, I can put a link down on the notes. I'm not affiliated. I'm not going to get paid for it. Just to let you know. And then dermoscopy. I'm a huge fan of dermoscopy. Like I said, I can't do my skin clinic without a dermatoscope now. I don't look at skin lesions now either with a dermatoscope because it gives me such a good clarity and idea of what that skin lesion is. So now it's the only way I can be certain. And actually that's what differentiates us and you eventually from the other clinicians who don't use a dermatoscope. I firmly believe it should be used in the same way that we use stethoscopes and otoscopes and oroscopes, ophthalmoscopes. This is the next main scope that you need. So another good thing to do when you're examining is looking for the ugly duckling sign. And this is an approach or a method used to differentiate certain lesions when you've got those patients who've got lots and lots of moles or lots and lots of seborrheic warts. You're looking for that lesion that doesn't look the same as the others. And it gives you a good idea because if all the other lesions look the same, they're not going to be the malignant ones. It's going to be that ugly duckling. So you can see on this example, that one on the middle right with the arrow pointing to it looks very different to the others. The others are nice and uniform, pigmented, round lesions, whereas this one is it's almost like a fried egg shape, isn't it? With central pigmentation and then the surrounding irregular, pinky, pigmented border. So obviously that's the one that your eye picks up, and that one needs a referral and a biopsy to check for malignant melanoma. And then again, nails. Always examine the nails. You want to look at if all the nails are affected or if one nail is affected, because again that guides you with your diagnosis. If all the nails are affected, then you're looking at something systemic like psoriasis, lichen planus, or some deficiency, whereas if one or two nails are affected, you're thinking, is it an infection, is it trauma? So hopefully you can see some signs on this nail. This is a typical nail of a psoriatic patient. They've got erythema and swelling of the nail bed. You can see the end is sort of coming off. So that's a dystrophic nail. It's not growing properly, and it's got the pitting, the classic pitting that you get with a psoriasis patient. And like I said before, you always need to dig around. Always, we're basically detectives, aren't we? When we're taking our history, when we're examining, we're doing detective work. And if you don't look for it, you won't find it. Okay, so this is a patient who came, he was in A&E, a 90-year-old chap who fell off his bike, refused to take his hat off. And the doctor was sort of wondering why you're not taking your hat off, and so he sort of insisted and just got him to take it off, and he found a huge sort of ulcerating lesion, which this man had had for about 10 years, and he was just afraid or didn't want to bother the GP with it, but you can see had he presented earlier, something could have been done about it. I mean, he did have a wide local excision, and it healed with secondary intention. You can have a look and find out what that means. And it healed well, but he wasn't volunteering that at all. So you always have to just dig a little bit deeper, and you will find pathology. There's plenty of pathology out there. And lastly, like I mentioned before, always have a feel of the lesions or the rash. It gives you a nicer idea. So, things like flakiness, seborrheic dermatitis is a flaky condition. Things like seborrheic warts and actinic keratoses, I feel a bit more rough compared to melanomas. BCCs aren't particularly rough feeling. And also stretch the skin. You can see this is the same lesion, but the one on the left side is very different in appearance to the right, and also having a decent light source can give you a good idea of what that lesion is. Okay, good. So that's it for examination. Thank you.